Hi, everyone. One of the biggest themes at the San Antonio Breast Cancer Symposium this year has really been a talk about SERDs. What are SERDs? They are selective estrogen receptor degraders. So when we think about, let's say, taking an aromatase inhibitor, which blocks estrogen production so that there is nothing to bind to the estrogen receptor, and then the cancer cells can die, what happens is sometimes the cancer cells develop resistance, and they develop resistance in the ESR1 ligand binding domain of the estrogen receptor, which means that the estrogen receptor essentially starts functioning independently of that estrogen receptor binding. So even if you're on an aromatase inhibitor, it's blocking estrogen production, the estrogen receptor is just starting to function on its own. It doesn't even need that estrogen to bind. And so that's how resistance can happen to aromatase inhibitors. Now, what SERDs do, they actually degrade the estrogen receptor, and some of the more novel SERDs also completely block its activation as well. So we've had a SERD around for a very long time called Faslodex or fulvestrant, but this is a drug that requires an intramuscular injection, and it doesn't have the best bioavailability. And for some of the mutations in ESR1, fulvestrant is going to be ineffective. And so there's really been a need for the development of novel SERDs. And what's really amazing is that the SERDs being developed now are all oral. So they really have good bioavailability, and there's no need for a monthly injection. So I think that's really, really exciting. Now, we already have one approved SERD on the market. That is elacestrant. It's approved for ESR1 mutated, hormone receptor positive, HER2 negative metastatic breast cancer. We saw at this meeting the results of another SERD from the EMBER-3 trial, imlunestrant, combined either alone or combined with Verzenio, again for metastatic breast cancer. And I have a post on that, so check that out. And there are a number of SERDs in development, and they are also being used in early stage hormone receptor positive, HER2 negative breast cancer. And there's a number of studies in the early stage setting. Some look at starting that SERD in the very beginning before you go on endocrine therapy. Some are looking at switching to a SERD after 5 or so years of endocrine therapy. Some are switching based on circulating tumor DNA. So a number of studies in development, and they all are doing something a little bit different, and they're all testing slightly different SERDs that come from different companies. And so it's going to take some time for us to see the data in the early stage setting, because we have to wait to see if that SERD is going to prove to be effective. But, one of the things really that the two things that are really important in the early stage setting, one is going to be, how effective are the SERDs in reducing the risk of recurrence compared to our standard of care endocrine therapy. But also, what about the toxicity? And I think this is a really important point, because they're not blocking estrogen production, but degrading the estrogen receptor. We hope that the toxicity will be less than that of our standard of care endocrine therapies. So lots coming in this space, and a really, really important one to watch. Let me know your questions.